Kia ora koutou katoa. For those who don't know me, I am Stephanie Valent. I am an emergency medicine specialist working up in Whangarei in New Zealand. And it's my pleasure today to introduce this webinar. And before we get into the nuts and bolts of it and introduce our moderator and guest speaker, we'll just have a few words on the newly fledged New Zealand Prehospital and Retrieval Medicine Society. So apologies to anyone who's listening to this for the second time. We did briefly go through this in webinar 1, but for the new people on board, we'll just get you in the loop. So the NZ Farm Society was born from a bit of a vacuum in this country for a space that brings together diverse professions and specialties to collaborate and advance the field of farm in New Zealand. It's a collegial space to collaborate and share resources, ideas and direction. I won't read from our charter today, but I do encourage you, particularly those who haven't already, to visit our website. That's www.phrm.nz and have a look at our charter. It basically explains our purpose and goals. I'm excited to announce that our membership continues to grow and is represented by clinicians across the two motu of New Zealand. Sorry, I should say 3, but all the way from Dunedin, Queenstown, West Coast, Christchurch, Hawke's Bay, Bay of Plenty, Auckland, and as far north as Bay of Islands. So that's really exciting. We're also encompassing a few medical specialties, including anaesthetics, ICU, emergency medicine, and rural hospital, which is really nice to have that diversity. We are also open to membership from paramedics and flight nurses. So I really encourage people from those sectors to come and join. And you can do that through our website. Although we've started as a group of doctors, I do encourage that membership from our paramedics and nurses, as one of our key sort of tenets is that inclusivity. Right, so we'll get into it now. I would like to introduce Dr. Chris Duncan, who will be our moderator today. Just note that this is recorded for our website, so people can refer to this webinar later on. Chris Duncan is a farm doctor who works in Auckland and an emergency medicine specialist at Middlemore Hospital. So welcome, Chris.
Thanks, Steph. So as moderator tonight, I'll just quickly lay out some rules of engagement and then I'll introduce our speaker. So important that this is respectful discussion. You'll see at the bottom, there's an opportunity to ask questions. Essentially, Tim's going to run this like a lecture, but instead of putting your hand up, just pop questions in the bottom and I'll keep an eye on those. And at the end of Tim's talk, I'll ask some of those questions to Tim and let him answer those. Importantly, everybody that's speaking today has a professional job in lots of different places, but their opinions and views are in a personal capacity this evening. So I first had the privilege to meet Tim back in 2007 when I arrived in New Zealand, fresh off the boat, baby-faced junior doctor. And the enthusiasm and passion Tim displayed as a leader within emergency medicine helped me convince me that emergency medicine was the specialty for me. Fast forward, and that same passion and enthusiasm was evident in Tim's support and leadership in the early days of what was then Auckland HEMS, a fledgling outfit that was pioneering the concept of interprofessional teams in the northern region of New Zealand's aeromedical sector. Tim's a specialist in emergency medicine, and he's also got subspecialty recognition in both intensive care and pre-hospital and retrieval medicine. He's been a senior leader for over 20 years, probably nearer 30 now, I guess, through Auckland City Hospital, South Glasgow Emergency Departments, unscheduled care lead at the Queen Elizabeth University Hospital, and also pertinently for this presentation, Associate Medical Director for the Scottish Ambulance Service. Perhaps most useful to know is Tim's other role is clinical lead for the Advanced Critical Care Programme for the Scottish Ambulance Service. So it's me great pleasure to introduce Tim, welcome him to the webinar, and look forward to his presentation this evening titled The Scottish Trauma Network and the Concept of Interprofessional Red Teams. Thanks, Tim.
Great. Chris, can you just confirm you can hear me okay? We're all good? Yep,
I'll leave
brilliant.
you to it, mate. Fantastic.
Thank you very much. Thank you very much. Good evening, everybody. Thanks very much for the invite. It's great to be back in New Zealand. I'm currently sitting here looking out over the bush, over to the Harbour Bridge, and it's considerably warmer than the 3 degrees it is currently back in Glasgow, where I'm headed back to, unfortunately, next week. But the Guinness is better there. Okay, so I'm just going to start sharing my screen and do a bit of a talk through what's happening in Scotland. I guess this is just to give a little bit of a very personal flavour of what's happening there. And what I would like to do, I'm just going to come on to share my screen here and see how we go, make the tech work. Here we are. And if I could just get a wee bit of a confirmation from my colleagues. Is that sharing okay, guys? Yep, there we go.
Yep, looking
Chris,
good, Tim.
Good. Right, nice. I'm just going to come back a couple of slides. Right, so I've called this Getting It Right in Pre-Hospital Trauma Care. What I'm essentially going to do is this is going to be a bit trauma focused. But obviously, I'm going to touch on other aspects of critical care. And it's a little bit of, like I say, marking Scotland's homework in this space, and be very glad to hear of any comments, feedback at the end as to what we're up to. We've got many challenges, we've got many opportunities, and it's just a matter of turning challenges into those opportunities. So I'm going to start with a case. And try and just focus what it is I want to talk about. This is anonymized case from about 3 months ago. There's a little map of Scotland down in your bottom left-hand corner there, which is the central belt of Scotland. You can see Glasgow and Edinburgh. And just south of Glasgow there in Ayrshire, in a little town called Galston, quite near to the medium-sized town of Kilmarnock, there is the scene of our RTC. So our RTC as a car has gone into a tree. There are 3 occupants in the car. There is a driver who's a 45-year-old female who is significantly overweight, is trapped by the dashboard. She has an obvious compound femoral fracture with a lot of blood in the footwell. She's GCS 14 and shocked with a BP of 80-60, tachycardic, tachypneic, but is conscious and talking and almost making sense, and her SATs are okay. We have a front seat passenger who's 67. The door is jammed, but she is not, no parts of the vehicle are intruding on her, so she's just contained but not trapped. She's GCS 15 with a head wound. She has a significant seatbelt bruise across her chest and abdomen. She's very tachypneic, respiratory distress. Blood pressure is low at 100/50. She's tachycardic, quite significantly tachypneic. She's fully conscious, but her SATs are reading 87. And she's a very obvious, even through the door of the car, got a left flail chest with poor air entry. On the back seat of the car, there's a 6-year-old who is unresponsive, GCS 3, not trapped, snoring, with a blood pressure of 90/70, a heart rate of 60, respiratory rate of 8, and saturations of 99, with a major obvious mid-face fracture with significant bleeding. Currently, as it stands, we've got 3 local ambulances from the station at Kilmarnock who are on scene. These are paramedic crews. We have a major trauma centre in Glasgow, 55 minutes by road. We have a trauma unit about the size of Whangarei in 15 minutes by road. We have a pre-hospital critical care team in EMRS West available at Glasgow Airport, who can be 30 minutes to scene by air, including start-up and landing. And we've got a critical care paramedic who's 20 minutes to the scene by road. He's just finishing off a job in South Glasgow, so he's a little bit closer and thanks to his Skoda Octavia, can get there in 20 minutes. So I'd like maybe just to hold the thought about this job, and then I just want to move away from that, and we'll come back to that at the end. I guess what I want to present is maybe a hierarchy of needs in trauma. There's the sort of, like, you'll be aware of the sort of hierarchy of needs, but in trauma, people have got a personal, if you like, investment in what happens to them if they have a bad accident. They want to be, first of all, alive, but they also want to be functional, and be able to be independent. And ideally, at the top of that triangle, they want to get back to their work and family, and back to the life that they had before. So, there's a personal hierarchy of needs. We've got to get them alive, functional, and back to work and family. But there's also societal hierarchy of needs in trauma. And I do want to just touch on this a little, because it features into what we do in Scotland. And that's, we want to minimize death, but not just because, it's not great to have the tragedy of people dying in accidents, but there's a societal cost to death. The ripples from a young person dying in a road accident or in a stabbing, ripple outwards and affect somewhere between 40 and 50 people, some of whom may never be able to go back to work themselves. Maybe the loss of a father. You may render a child without a parent. So the societal costs are significant of somebody who dies. But in addition to that, if somebody survives but isn't functional, there's a cost to society of that dependent disability. The costs of care, at the Glasgow Outcome Score 4 level of permanent nursing care, versus them going back to playing football on a Saturday, having a drink with their mates, and returning to their job and their family. So we wanted, society has also got an interest in returning those patients back to tax-paying status, if they're of that age. But there's a final thing which is, I think, really pertinent with all that's going on in the world at the minute, which is that you want from your society for you to feel that the society around you and the government around you, if the worst thing happens to you, that people will come, they will rescue you, they will care for you, and they will get you the best possible outcome. So you want any system we've got to deal with trauma to be resilient. It has to be caring and compassionate, and it has to be equal. And there is an importance put on equality. That equality can be socioeconomic. It can be protected characteristics, or it can be geographic. So I think one of the things that we maybe miss a trick on when we're talking about trauma is just the societal half of this. And just to emphasize that, I just want to talk a little bit about what some of my rehab colleagues in the trauma network talk about a lot. And that is these outcome scores. One of my colleagues, and thank you to Karen, one of the rehab coordinators, who talks to this slide, which is, this kind of teaching that they do, which is that after a severe brain injury, there are patterns of recovery ranging from D, an ongoing vegetative state, up to A, which is a progressive rapid recovery. And as you can see, this is like a theoretical graph, but it is demonstrably real in terms of plotting patients on it. And every outcome is possible. But what I would like to do is to say all of the bit in the mid, apart from the little dark box in the bottom left-hand corner, the rest of this is our rehab colleagues, our surgical colleagues, nursing care on the wards, good antibiotic stewardship, all of those things that happen in the rest of the graph. But if we focus on that little box in the bottom left-hand corner, that little box in the left-hand corner is us in pre-hospital care. And it sets the gradient for the patient's journey. If you like, it sets the substrate for how a patient's going to go after specifically a brain injury, but I think this can be extrapolated to other multi-system trauma. So what does this mean? Well, if we look at, if what we want to do, how we're setting this course is going to be dictated by the avoidance of bad stuff that we know leads to bad outcomes, hypoxia, hypotension, or reduced cerebral perfusion. And how can we influence that? We want to have open airways, severe chest injuries dealt with to avoid hypoxia, stem uncontrolled bleeding, and deal with expanding cerebral hematomas or worsening intracranial pressure. So these are the bits that we can influence, and we can then set the trajectory, which then dictates the patient's outcome, which has not only the personal bit to get them back to work and family, but also the societal bit to reduce the cost. Is this a real thing? Well, in the traumanomics of the Scottish Trauma Network, if we look up here, this was back in 2018 to 2021, where a lower severe disability and upper severe disability, these are people who are dependent, compared with now, where we've got the pre-hospital systems linking into the major trauma network. It's reduced the incidence of lower severe disability from 7% to 3%. That is an estimated saving when you estimate that at 334 patients at a cost of £60,000 per annum each, is a total crude saving of £20 million in terms of just getting it right. So when you spend 46 million on a trauma network, you save 20 million on rehab costs. And I think this is such an important point when we're dealing with politicians and lobbyists. It's not just about the people, it's about the money. So if we go back to then, how do we work out whether avoiding these hypotension and these critical insults and things, what have we got to look at? Well, as we all know, the evidence here, Mike's doing his bit there, finding us new evidence and things, but when we look through it, essentially these are the ones that have been trawled through and regarded as significant in the UK, and have been adopted by the Scottish network, which is that after major trauma, we want to get an ambulance there in 7 minutes. If it's a penetrating injury, you've got 10 minutes and then you have to go, because the mortality increases by 1% every extra 1 minute you spend on scene. We want to get an RSI for a definitive airway within 45 minutes of the 999 call or the 911 call. We want to get the tranexamic acid in for bleeding 1 hour after injury. And if a patient has got uncontrolled non-compressible hemorrhage, to get them to damage control surgery, get them to the surgeon 60 minutes from their injury. We're going to get them antibiotics for their open fracture within 3 hours of their injury, and to a neurosurgeon within 4 hours from injury for an expanding hematoma. Now, I appreciate that we can dissect each one of these points and review the evidence for each one of them, but my feeling is that this is the best we got. These are mostly in the NICE guidelines in the UK, and they are the ones that have been adopted for us to try and make sure they happen in the Scottish network. So just about Scotland's network, this is a map of the various health boards in Scotland. We have got 4 major trauma centres, one in Glasgow, one in Edinburgh, one in Dundee, and one in Aberdeen. And the geography, as was mentioned maybe at the start, Scotland, like New Zealand, a population of about 5.5 million, and it's got again, like New Zealand, lots of mountains, lots of rivers, lots of bits that are underpopulated, and lots of big cities. So if you like, you go from shortbread tin Scotland up here in the Knoydart Peninsula, where people like to go climbing in the mountains and falling off them, down to sort of crowded cities in Edinburgh and Glasgow, which, Greater Glasgow have about 1.5 million, Edinburgh about the same, with a spread of population between those two cities. So if you like, you traveling around Scotland, you travel from whiskey galore through to train spotting pretty quickly, and both are equally valid views of Scotland. So trying to provide trauma care for these types of environments, and like I say, for that societal thing of it being equal and pursuing geographic equity is challenging. So this is currently how we do it, and even this slide is becoming a little out of date. But we have if you like, the ambulance service as a whole is that central green bit. So we've got our team of around about 500 frontline ambulances who will respond to 999 calls. But within and they are our green tier and our green tier of responders. But also within Scottish Ambulance Service, we have the yellow tier of responders, which are our critical care paramedics. And they are a bunch of now up to about 28 critical care paramedics who have got 2 years of additional training. They're usually recruited from a very experienced background. They've usually done 5 years on the road, recruited, do a uni course, do a master's, and 2 years in, and it's an apprenticeship to become a critical care paramedic. So we have that tier of critical care paramedics, and I'll come on to what they do in a minute. And then we have 2 EMRS teams. There's 2 ScotStar EMRS teams, West and North, and they are our red teams. And they are our critical care teams who respond on behalf of the ambulance service. And you can see by my little drawings of little yellow helicopters, they each have a helicopter. One is state funded and one is charitably funded. Down at the bottom, you can see some discs that overlap into the larger green one. And this is our hospital-based pre-hospital teams, Medic One and Tayside Trauma in Dundee and Edinburgh. These teams this is where this slide is becoming out of date because Medic One and Tayside Trauma are currently being replaced by an EMRS East. So they will come into the body of the fold. And then we have Basic Scotland, which are our GP responders in remote and rural Scotland, who also carry the same skill set as the critical care paramedics. They're all looped around a trauma desk, or what has now become a critical care desk. And that critical care desk screens every 999 call coming into Scotland to see who to deploy. In addition to the 999 ambulance, they will also deploy red or yellow assets to go and assist. And then at the top, very top left and right of these is further complicated by the fact that we occasionally, particularly in winter, work reasonably closely with the Scottish Mountain Rescue Service and with Maritime, with the Coast Guard, who provide a lot of air cover and some of our water-based rescue. So to get into some of these roles in a little bit more detail, what do our paramedics do? What's the level of their empowerment in the current sort of Scottish context? Well, they have got a HOT protocol, so they've got a traumatic cardiac arrest protocol they can roll out to secure the airway, oxygenate, decompress the chest, and provide a fluid bolus through intraosseous access if required. We've got, they give antibiotics. They've got a reasonably extensive arsenal of analgesia with oral dispersible morphine, standard morphine, and Penthrox, which has become, of which more later. We have revised and updated our tension pneumothorax guidelines, and so they carry ARS needles. If you look at the bottom right-hand corner, you'll see a scary CT scan of an ARS needle indenting the pulmonary vasculature. And one of the things that we've been trying to do in the trauma network is prevent further harm. So we've had fairly extensive revisions of when ARS needles get used and deployed and how they're inserted. They carry tranexamic acid, of course, not just for bleeding, but for head injury. They could give adrenaline for post cardiac arrest, and they carry midazolam for sedation in addition to carrying it for seizures. They've also got all of the immobilization tools, and then they're empowered to use a triage tool to make a decision, which is in the top right-hand corner there, as to where to take the patients. So each of them have a trauma kit, and this is the sort of level, if you like, of their response. Our feeling in the network is that 80% of the good that we do in trauma is done by the front tier, is done by the green tier. If we come on to the yellow, which is our critical care paramedics, the critical care paramedics have additional surgical skills of thoracostomy, They have additional analgesia in that our standard ambulances don't carry ketamine, but our critical care paramedics carry both the 10 milligrams per ml plus also the 50 milligrams per ml. They are the ones who staff the critical care desk. So they're the ones who are looking out for jobs. They are trained in point of care ultrasound. They've got a reasonable armamentarium of toxicology drugs, including magnesium and sotabic and calcium gluconate. And one of their more common jobs is to get called to assist the police with agitated delirium, hence the Hulk in the bottom right-hand corner. And they are significant expertise in managing agitated patients with or without trauma. They are also our resident experts in post-cardiac arrest management, in inserting intra-arterial lines, starting adrenaline infusions, triaging patients to cardiac arrest centers and to PCI labs. So they are a very busy cohort. I've put in brackets after CCP GPs because some of our basics responders in remote and rural are GPs, and they are equipped with the same protocols, the same sets. They don't have extended skills beyond our critical care paramedics, despite their medical degree. We keep them within the yellow tier because they are solo responders. And this is a bit of a recurring theme, that solo responders provide yellow skills, and the red responses require a team approach. So our red teams, which was, I think, that the subject, the main kind of like meat of what we're getting to, are our EMRS teams and our two ED-based teams. But I'm mainly going to talk about the EMRS teams, which are the stood-up, suited and booted teams in both Glasgow and Aberdeen. They've got access to a road vehicle and to a helicopter, and they will respond. Their roles are essentially threefold. They provide a pre-hospital response by air or by road with blood. They're one of the more common interventions they get called to is to provide anesthesia and ventilation. Thoracostomies, like the critical care paramedics, surgical airways, again. Amputations, very, very rarely done. I think we've done 2. Thoracotomy, quite common, about 1 a month for penetrating cardiac injury. We've become a wee bit similar to London in that regard, not quite at their volumes, but it's not an uncommon procedure. And then complex medical, and this is increasingly becoming a feature for where very complex toxicology or very complex medical, which can be obstetric, pediatric, but tox is one of the main ones. We've had a rash of sodium nitrite poisonings, which require large doses of methylene blue plus a lot of blood, and then consideration for being taken onto ECMO. And so some of these more complex ODs will prompt a red team response. In addition to the pre-hospital readiness, these guys also provide our retrievals, and these are the time-critical care retrievals. And these are divided into sort of 3 types. There's the rescue retrieval, which is like GP surgery on a small island like Colonsay in the Inner Hebrides, which has got 1 GP. If he gets somebody in who's got a severe head injury, taken an overdose, or is in status epilepticus, he's going to need help pretty quick. And so that's an immediate dispatch, an IFT1 transfer, where the team will go and provide essentially almost like a pre-hospital response, where they'll stabilize, intubate, put the lines in, organize a critical care bed, take the patient directly to a critical care unit. The critical care medicine transfers are IFT2. So these are from, if you like, smaller hospitals where they're needing to be transferred into a bigger hospital that's got more specialist surgery like neuro, or to a large tertiary intensive care unit. And these will be from the hospitals, like the larger hospitals in some of the islands like Stornoway, Shetland. We don't currently go to the regional district generals They tend to be done by the local hospitals, but so a lot of this work is out to the islands, particularly common to go to Shetland, Orkney and Stornoway up in the Isle of Lewis. And then there's a lot of advice and top cover calls. So top cover for paramedics out there dealing with a difficult patient, to the critical care paramedic who's on the desk, and also to GP colleagues out in remote and rural. And in addition, the pre-hospital red team forms a site medical team for a major incident and provides a tactical medical advisor who goes and sits beside the CCP in ambulance control to help manage and distribute casualties from major incidents. Just as a guide to how busy is the service, these are the EMRS figures, so these exclude the hospital-based teams, but you can see that primary missions in the year October 23 to September 24, 1,221 primary missions. That's between EMRS North and EMRS West. If you look to the bottom, you'll see the West team is about 3 times as busy as the North team because of population. 337 secondary transfers, that's those IFT 1 and 2s, that's the interfacility transfer from the Intensive Care Society, by the way. And then 913 advice calls. This is another one of those economic things where quite often we're supporting a GP making a sensible end-of-life decision. For example, somebody with terminal cancer has a fall down the stairs, breaks their neck, is post-cardiac arrest, not breathing, but the crew have got ROSC. We will often support a crew or a GP to provide, palliative care locally rather than transfer the patient away from their relatives. We'll make some, local arrangements to palliate, and that's a reasonably common one for patients with advanced medical pathology and requests for secondary transfer. But it's a big bit of the work and a big bit of the economics of the system. So it gives you a wee bit of guide as to just how busy the system is. I did want to just touch on the major incident piece because, it is a significant thing when we talk about national resilience. Touching on some of the major incidents, obviously on the far left, we've got the COVID pandemic where the team were busy doing the COVID transfers. I particularly thought this was a particularly Outer Hebrides advert where there's no point leaving a half-shaved sheep. So this was the advice to get the second JAG when the COVID pandemic came out in Stornoway. We actually did quite a few transfers of COVID COVID pneumonia from the islands during the pandemic. Just middle, the top, we've got the Parke Inn attack where there was multiple stabbings in an asylum seeker hostel with all of the significant political and heat around that sort of incident. To the right of that, we've got a Stonehaven train crash, which again happened during the COVID pandemic. So mercifully, the train was relatively empty. There were only 3 fatalities, say only 3, devastating for those families, but could have been significantly worse. Down middle at the bottom is the celebrations after Rangers won the championship. Rangers fans, it's fair to say, like a riot. And the AMRS team were somewhere in the middle of that riot, dealing with a couple of complex head injuries. So that's a pretty significant event. We also had the COP26 conference with all the world leaders where AMRS provided the medical cover. And then in March 2023, and apologies to my North American friends on here, but this was allegedly a research ship, but it was staffed by large American men in mirror sunglasses that fell over in Leith docks, and a number of casualties were injured. And this was a particularly complex incident because a lot of the injured parties were workers underneath or behind that ship that fell over in its dry dock. But this just emphasizes the role of the red teams in major incidents. Do we get it right? Coming back to, do we get it right with the Scottish Trauma Network? No, we don't. We certainly don't. And we have had issues with the identification and then the subsequent tasking. What complaints do we get? We missed the job. We didn't send a team. We didn't send a critical care team. We didn't send an advanced paramedic. And the green team were left to fend with a very difficult, complex patient. We didn't send enough ambulances. We got the timescales wrong. We sent a helicopter when the weather was obviously sufficiently bad that they weren't going to get there, and we were relying on that. But one of the other really common ones is that we sent the wrong skill mix for the patient needs, in that it was obvious they needed an RSI, they needed blood or analgesia, they were a complex extrication, and we sent the wrong team and the wrong skill set to the job. And we've also had complaints about over-resourcing incidents where we've sent too many cooks, there's been ownership issues of the job, there's been little fractious turf wars between different bits of the service, and I'm sure this is common to everyone who works in pre-hospital care. What else do we get wrong? We've got all the things that we get wrong with the care that we provide on the scene. We've got inadequate treatment on one side, on the left side, where we've got airways that aren't secured that are then brought into ED, missed tensions, inadequate analgesia, common one. Fractures haven't been managed or splinted. They haven't had their antibiotics, their TXA as per the guidelines. But on the other side, we've got inappropriate treatment. We've had unnecessary or failed RSIs, unwarranted. I showed you that slide of the ARS needle, where we've had problems with the needle chest decompressions, over sedation of an agitated head injury, incorrect or overdone splintage. But one of the big ones for us has been delays on scene to provide interventions, where teams have spent too long on scene doing stuff that may or may not have been necessary, but it's led to delays in what is time-critical treatment. And we're really working hard on this one. And then do we take them to the right place? Not always. We under-triage, we over-triage, and we take too long to get them there, or we take them to the wrong place and then they need secondary transport, or something bad happens during that secondary transport because the wrong skill mix was sent. So there's issues with identification, issues with care, issues with triage. So what are we going to do about it? So what we do about it now is we've got a clinical governance structure where we don't we don't mark our own homework anymore. We all mark each other's homework. At the top of this diagram are the 4 trauma networks: the north, the east, the southeast, and the west. And then feeding into those networks, we've got our teams. We've got our red tier teams, our yellow tier, and our green ambulance divisions who bring patients into those networks. And at the bottom right, we've got the critical care desk who identifies these jobs. So what we now do is when there's a job where there's been an unexpectedly good or bad outcome, or where somebody's not happy, is it goes to this pre-hospital governance group where a report is prepared on aspects of identification, care, and triage. Each bit of the network is invited to comment. So the network is invited to say what state the patient arrived in, were they brought to the right place. The pre-hospital teams are invited to say what they saw when they got there, what they did and why. And the critical care desk is invited to review the call, listen to the recordings and say what they sent, why they sent it, and did they send it quick enough? And then it's a pretty critical environment, but hopefully appropriately so and positive, where everybody gets to see what everybody else did. So the red teams get to see, the pre-hospital intensivists get to see what the critical care paramedics did. The ambulance technicians in Fort William Ambulance Station get to see whether they took the patient to the right trauma centre. The trauma centres get the chance to complain that a patient was delivered with an unrecognised injury. And critical care desk get the pelters when they sent the wrong assets to the job and everybody was unhappy. But so it's a pretty robust group, but we keep it, we deliberately at this group that do not bring the people who are on the job. So we've got a tactical debrief that happens and a tactical report, and then this is the strategic group that reviews what actually happened. And when we're doing this and going through it, we look at the identification, the response, the extrication, and the care on scene. And with each bit of this, we're trying to sort out, did we send the right skills? Did we send enough transporting resources? And did we get the patient out in time? We've put a great deal of emphasis on the exit project recently about not waiting until the roof is off a car to get someone out who's obviously critically injured. And we've been great deal of Tim Nutbeam's work in the UK is being very influential on this, about just getting people out of the vehicles and helping them to self-extricate, or minimum time on extrication. And then the care on scene, which is the thing I'm going to talk a little bit about in the last 5 or 10 minutes. But then the transport, how did we get them there and where did we take them? This is a slide that I wouldn't expect to interpret, because I just want to break this slide up into bits, but this is our care decision matrix, where right back at the start, we talked about the things that have to happen, the things that are time critical. So the first part of this is that in those first 10 to 30 minutes, we're expecting certain things to happen. In the red bubbles, a traumatic cardiac arrest will get a hot protocol, that tourniquets will be applied for external hemorrhage, that basic airway care and needle decompression, if necessary, will be done, that TXA, pelvic binders and fractures will be splinted, that analgesia will be given, and that patients are packaged. And then at this point, they may well be whisked off to the nearest hospital. If there's a red team there, they can provide additional benefits. As you see in the red writing below, they can do a thoracotomy if it's a penetrating trauma, a crash RSI if the airway is completely unprotected, give blood if they're shocked, or sedation and anesthesia if the patient is too agitated, or for humanitarian reasons like severe burns, for example. But there's a bit that comes after this, which is the bit that is a real talking point in Scotland, which is to do extended care on the scene. Because if we haven't got any of those initial resuscitation, then we've got a bunch of patients who we could give blood to, we could put to sleep. They're almost certainly going to need to go to sleep within 45 minutes, but should we do it in hospital or should we do it here? Who should do it? Do they need a thoracostomy? Do they need blood and fluids? Do they even need pressors given? Do they need sedation, anesthesia? Do they need hypertonic saline for neuroprotection? And then do we do all of this stuff and then take them a bit further to the major trauma centre, or do we cut and run and just go to the nearest trauma unit, get all this done and dusted, and then take them to on secondary transfer to the MTC? This gets fed into, so all of these decisions get fed back to that clinical governance group, and then we run it through this care assessment tool to work out exactly what the course of actions that were open were, what the reasonable course of action that were open were, and did people follow that, or did they not? So to go back and close to the scene that we came in on, when we dissected this job, did we do the right things to get the patient back to their work and their family, back to being a taxpayer, and to not cost the country money in prolonged disability? Patient one falls into non-compressible shock. So we decided that the patient should be out of the car as quickly as possible. Tourniquet applied if that limb was bleeding significantly. They should, as a minimum, have morphine, antibiotics, and TXA. Probably a traction splint applied if we can get the critical care paramedic there in time to give additional analgesia, particularly before the traction splint goes on, so much the better. If the pre-hospital team are there, great, give them the blood. But the main thing, the whole focus of that job, was to get that driver to damage control surgery, because their pelvis may be gone, they may have something in their abdomen, and to get them to that surgeon. And they're making the decision as to go to the MTC, which, if you remember, was 55 minutes away, or the trauma unit 15 minutes away. And that may be nuanced by where exactly the treating team feel the bleeding was. If there was a high suspicion of a pelvic fracture, for example, then going to the MTC is probably the right bit, because the trauma unit won't have the interventional radiology or the orthopedic skills to deal with it. The front seat passenger can self-extricate, as according to the new rules on the exit project. Just wedge that door open and get her to step out. Then get her to sit down on a trolley, give oxygen, IV morphine, TXA, and sit them up. Consider a needle decompression for that chest if it meets the criteria, but not if it doesn't, and that's peri-arrest with critical hypoxemia. Sorry, I'm just picking up the messages. So then we go to but probably what this patient needs is intubation and ventilation plus a thoracostomy and straight to the MTC. These are the patients who do badly in trauma units because they often need the rib fixation. Finally, our rear seat passenger has got a critical airway. They've got to get pulled out of that car, simple airway done. They need an RSI. If that RSI can be done because we've got the helicopter landed and the pre-hospital critical care team, that is optimum. They get intubated and they go to the trauma unit where the neurosurgeons are. But if there's going to be any, then maybe the right thing to do is to scoop them up and run them to the trauma unit, which you remember was 15 minutes ago, and arrange the secondary transfer. So just to close, these were our key times. I think the emphasis we're pursuing in the Scottish Trauma Network is time to intervention is the metric. Doesn't matter who's doing what or what egos are involved this time. It's just getting stuff done. But you've got to do it well or don't do it. Bad RSIs are worse than no RSI because you can just bail to a hospital rather than do a bad RSI. Reduce variation, but make each other better. So at each job, you're supporting each other and making each other better. And this is particularly true for our green tiers, and develop the system. Save the time on scene, save the lives, and save the money. And just as a final note, cooperation is so much better than competition, particularly when you're at a job and you've got 3 people trying to die in a car that's just hit a tree. Okay, I'll stop talking at that point, and apologies. I've gone over a bit. Chris, my apologies.
No worries at all, Tim. That was fantastic. Thank you very much for that talk. We've got a few questions to ask, if that's okay. And I'll go through, there's some online, so excuse me reading through them. I think one of the first questions I might ask is to do with that very last slide. And there's a bit of a buzz phrase at the moment about ad hoc teams or swarm teams coming together. Is there anything you've done prophylactically or anything that you've done to try and improve that integrated care delivered when the different teams collide together? So when you've got a green team and the yellow team arrive, or a yellow team and the red team arrive, what have you put in place to try and get those teams working well together?
So the critical care paramedics are very much friends and colleagues of the pre-hospital critical care teams. They work incredibly closely with them. We provide a lot. They often came from the pre-hospital critical care teams. They often go back and work with the pre-hospital critical care teams. There's a lot of interchange of personnel. So we know them really well, and the working relationships are such that they will often run the scene. So the critical care paramedic will turn up, and then the red team will come at the back of them, often 10 minutes later. They will have set up completely. They will have done, if you like, for example, started your delayed sequence intubation. Everything will be done. And then usually what the red team will do is then they'll arrive. And I think a very important part of this is that certain procedures don't belong to any particular specialty. You know, we don't. We encourage people to sort of swap tasks around and kind of trust each other. Our only rule is that we have to have 2 skilled people to do an RSI, because we just believe that having one person having a paralyzed patient is just too risky. It's just too distracting. There's too much else going on to have a paralyzed patient on a ventilator with a whole bunch of other stuff going on. So we have a minimum of 2 skilled operators doing an RSI. But apart from that, like for example, the CCP as in the red team will often do the tube, for example, or we'll interchange the tasks. But I think particularly with the green teams, if you've got a newly qualified paramedic, it might be their first IO needle in a humeral head. Just talk them through it, get them to do it, and then these swarm teams, they become delighted to see you. They're really glad because, oh, good, we're going to get to do more and learn stuff because these guys are here, rather than these guys are going to nick all our stuff and do all the interesting things. And I think it's that, being truly democratic about it. And it comes back to that cooperation more than competition. The clinical governance is helping that, Chris, because when you kind of challenge each other a bit, there's a bit of respect develops that, you can't be a dick at these jobs because somebody's going to call you out in the next CG meeting.
I might go straight onto that CG, Tim, actually. And how let's just get to that question. So you mentioned that clinical governance has lots of buy-in from different groups. How did you get that set up? How did you manage to get people from hospital and people from the ambulance service and people from the helicopter teams to all agree that it's a good thing to review the cases together? I mean, it sounds obvious, it probably is a good thing, but how did you convince everyone to give their time to do that?
Because because it was their idea pretty much, Chris. You know, if you want somebody to buy into something, make it their idea. And to be honest, it pretty much was, because that we were getting emails, maybe up to 20 or 30 emails a week saying this job didn't go well and wish you'd done that. And we couldn't keep up with the correspondence in the, you know, in the trauma team in SAS. And we thought we're going to have to have some way of managing this, of logging these complaints and issues and making sure that we're feeding them back and discussing them. So we said, hey, why don't we have a system where they're logged on a database, we give them an immediate feedback, we give them a download of all the calls, give them a download of all the assets, and then we say, if there's something significant to it, if somebody's having a bit of a grumble, we'll phone them up and say, hey, do you want this to go to CG? They'll either say yes or no. And if they say yes, well, that's fine. Then it all goes to CG and all the various players are alerted and it goes in. But I think folk we've got buy-in because they wanted it. I think really they felt that the ambulance service weren't investigating these in a way that we should. They can be a bit uncomfortable, Chris. Like, I've had one of my jobs reviewed and it's pretty uncomfortable. But you just, I think, have to go into it with the knowledge that hey, these people aren't having a go, they're trying to make me better. At least that's what I tell myself. They're probably wishing they all just retire and bugger off. But anyway, but there you go.
Awesome. Thank you, Tim. I've got another question about the rural geography of Scotland, which is probably similar to the rural geography of New Zealand. And it's about, how did you decide on the numbers of teams, the skill mix of teams, and the locations for those teams?
Okay. The location of the trauma centres was utterly political and out of our hands. It was set by the Scottish Parliament, who control, and there was a huge argument that, does a country of 5.5 million need 4 trauma centres? I think everybody clinical feels probably it doesn't, but the politics of it were that we had to have 4, and the 4 centres are working very well, but the volumes at 2 of them are lower than volumes at the other 2. So it does make it a little bit unequal. So the teams form around the nidus of where those trauma centres are. So Aberdeen and Glasgow are very natural places for the red teams. And then the 2 other red teams are historic teams that were operated out of the EDs. I think we're now recognising that we've got patches, particularly remote and rural Scotland, where it can take us an hour to get a red team. You know, that geographic equity isn't being missed. We recently had 2 Spanish fishermen who were caught up in the winch mechanism of a fishing boat 250 miles north of Stornoway. You know, so that's a hugely complex, you know, red team to cover. You know, how do you cover that? Both had traumatic amputations, both required tourniquets, both had to be flown into Stornoway, but we sent the red team up to meet them in Stornoway Hospital. So you try and get it all to network together, but it's largely been an evolution rather than a planned process as to where the red teams are. And we've got real problems in Edinburgh at the minute because the Medic 1 team isn't operating out of the department, and we need to in a hurry get an East team put into Edinburgh because it's the capital, it's a big population centre, and we're feeling a bit exposed in Edinburgh at the minute.
And volume for yellow teams, how did that come around?
So the yellow teams, the critical care paramedic program is reasonably recent. We've only had CCPs for just over 10 years. And it was born out of a pilot scheme started by 2 ex-EMRS retrieval practitioners who and then developed in conjunction with one of the universities in Glasgow, who developed the sort of masters in advanced practice. And again, it was rather organic. We got money from the Trauma Network, so that all of our critical care paramedics are funded by the Trauma Network, which is quite good. But the linkages are they're so interwoven with what we do that often what will happen is, if you get a red team who go to the scene of particularly a multi-casualty accident, they will moan their heads off if they didn't have a critical care paramedic. they will really complain, where's my CCP? And you go, well, it's not, so it's, and equally the CCPs can get a bit exposed sometimes if the red team are busy. That we've had a couple of real tricky jobs of people who've jumped off balconies inside prisons with agitated delirium due to drugs, with major injuries, and trying to get assets into prisons is enormously difficult with the various gates and things like this. And we, some of our critical care paramedics have been really sweating, waiting for a red team to come and give them a hand, but done a fantastic job. Some large guy with bad head injury who's had 4 milligrams per kilogram of IM ketamine because he was so unmanageable. So I can't, sorry, Chris, I can't remember what so just interwoven, basically.
Yeah, no, that's great, Tim. Steph, I might hand over to you if you've got any questions you'd like to ask already on the chat.
Yeah, there's a couple more. So Tim, in the, I'm going to call it the SAS, you may have touched on this really briefly, but how do you manage clinical coordination and making sure the right team get to the right patient to deliver the right care?
So one of the critical care paramedics is sitting in ambulance control, looking at all of the 999 calls coming in across the country, and then they're doing silent interrogation of those calls. There's certain things that are not quite an automatic send, but pretty much, high falls, chest stabbing, multi-casualty RTC with unconscious casualties. There's some pretty automatic ones. Entrapment in industrial or farming machinery, pretty much an automatic dispatch. There's often ones that are kind of weighted. We'll often send one of the critical care paramedics who will then, shout us up, and give further details. But co-responding like a CCP and a red team is quite a common response. But because it's one of the CCPs who knows exactly what the teams are and knows the geography and understands the flying, they sit beside an air dispatcher as well. So, we know where the helicopters are, what the weather conditions are, and obviously the weather in Scotland is a not insignificant factor. So it's done through that CCD, which is, if you like, a bit of a jewel in the crown for identifying it. Their stand down rate for dispatching red teams sits around 23%. And we think that's probably about right.
Nice. And so kind of on that, a question that's often asked in the last minute is how do you keep that local knowledge from the way out far islands and the type of work there? How does that feed into that centralized coordination function?
So each of the EMRS teams has a liaison coordinator who works with those islands. Mine's Stornoway in the Western Isles. So once a year we go out and we do 2 days of teaching and training and a couple of pints and a curry usually with them. And it's very much done on personal relationships. They understand the teams really well. We recently had a big one of the local MSPs in one of the islands, was saying how they can only retain GPs in these islands if they know that they've got that retrieval team coming out to bail them out. So if you like, those relationships are built up over many years of multiple jobs. EMRS itself as a service has been going for just over 20 years. So those relationships have been built up and are very, very strong with the rural hospitals and rural communities.
I feel like that's a really important message for us where we are at the moment. Tim, I think we're probably done for time. So I just want to say a massive thank you to you bringing your wealth of knowledge on your system, but sort of in the context of the international, systems and your work in New Zealand. So that's really powerful for us. Thanks, Chris, also for your lovely moderation today, and a massive thank you to our attendees who have come tonight. Your support's really important to us, and please do spread the word to other interested colleagues. This webinar has been recorded, and will be posted on our website. So that's www.phrm.nz. That should be up in the next few days, along with webinar 1, which was also very interesting. So big thank you again, Tim, And to all that attended tonight, huge thank you and good night.